Hello and welcome to episode 3 of Opt to Thrive, the HRT scandal, everything you need to know.
Welcome to Opt to Thrive, your go-to podcast for women's wellness in midlife, designed to educate, support, and inspire you to live your very best life. And now your host, Dr. Karina Sims.
It's another spectacular day out there. The sky is blue, there's a little breeze, the daisies are kind of flipping around in the breeze on my daisy tree. Lots of little blooms out there, some light pink and orange roses, and even some little purple flowers on the rosemary. So it's a good day here in the sunroom. And as I promised on our last episode of Opt to Thrive, good day to talk about hormone replacement therapy, or also known as menopause hormone treatment. So hormone replacement therapy, HRT, has been renamed MHT, menopause hormone treatment. The idea was to get away from menopause as a disease rather than a natural state of life. So getting away from the idea that we're replacing something that the ovaries should be making, because they're not supposed to be making estrogen anymore after menopause. They're done doing that. So instead, MHT implies we're treating the symptoms of menopause with a hormone treatment. Some medicos get a bit hung up on this difference, and some might even suggest that using the terminology HRT is misogynistic. I'm not sure about that, but I do agree the most accurate medical terminology to use is MHT. But please forgive me if I occasionally, without realizing I've fallen back into outdated terminology, I use the term HRT. I suppose it just happens after using it for so many years. Okay, I've got a few reasons why I really want to talk about this. First and foremost, I think that we've been afraid of it for far too long for the wrong reasons. I think that the risk was blown out of proportion many years ago, and we haven't quite recovered from that. So I'm not trying to talk anyone into anything as far as the treatment goes, but I want people to know that this treatment is still on the table for women who it is appropriate for. And we're going to talk about that. We're going to break that down. I'm talking about menopause because it's an important topic. Half of the population is going to go through menopause if we live long enough. We're going to spend 30 to 40% of our lifetime in this stage. 80% of us are going to have symptoms. 20% of those are going to be severe, and 40% of us are going to have moderate to severe symptoms. And I think for far too long, women have suffered through it. They've often felt ignored, unheard, and invisible, and we can do better. So on our last episode, I brought up a paper I found from my own college, the RACGP, the Royal Australian College of General Practitioners. It was a submission to the Senate for the inquiry that's going on right now into the issues related to menopause and perimenopause. I looked at the inquiry online. It's open to the public, and you can look at the submissions that have been entered into the inquiry. There are a few women who wrote in with submissions of their own, and I've just taken a couple little excerpts from these letters just to show you where we're at. So one woman says, "In desperation, after not getting any assistance from my female GP, I went to my gynecologist for assistance, who told me I would just have to tough it out. Already feeling completely desperate due to months of insufficient sleep due to insomnia and severe night sweats, I asked her how long that it might be, to which she replied with a smirk, 'Oh, it could go for up to 10 years. Another excerpt from another submission. "I suffered from various symptoms including joint pain, dry skin, headaches, and lethargy. However, the symptom which caused the greatest concern to me as it impacted on my workforce productivity and my ability to be a good mother was poor sleep. I experienced insomnia every night at around 3 a.m. and struggled to get back to sleep. I saw GPs and psychologists about this, but no one realized it was due to perimenopause." The names of these women have been withheld. These are stories that are happening now, not 30 years ago, not 20 years ago. Now, these are happening now. We can do this better. this is what I'm on about. We talked about the need for education for our doctors and for our women. It's a complex situation when a woman goes through perimenopause, through to menopause, and then to postmenopause. It's got a lot more symptoms than we have previously probably given it credit for. And many of those symptoms are related to the decreased amount of estrogen now being made by the ovaries, which is what one of the hormones in hormone replacement or menopause hormone treatment treats. The estrogen, or estradiol in particular, is the estrogen that her body is now no longer making as she used to. Okay, so we talked about menopause being that one day out of the year, no period for 12 months. We can call it menopause now, but it doesn't mean the symptoms are gone. They can continue on for another 10 years and sometimes more. And we know that one of the things that the hormone treatment does well is especially good for those vasomotor symptoms, which is the hot flushes and night sweat. So if we look back over time, we can see that menopause has a very colorful history in terms of, first of all, giving it a name, and then secondly, trying to work out how to manage it. Through history, we've gone through things like the humoral theory, where it was believed that we had to balance our humors in the body. Humors meaning bodily fluids like bile, phlegm, and blood, and that a woman needed to menstruate in order to balance the humors. And when she stopped menstruating, like in menopause, she became out of balance, and she was then thought to be susceptible to illness or disease. And so they did something called bloodletting, where they've opened up a vein and let some of the blood out. Another treatment phase was cutting the ovaries out. Unfortunately, surgical outcomes were not as great as they are today. A lot of women died as a result of that operation. There were people eating ground up ovaries of pigs and cows. At one time, we were thought to be suspicious enough that maybe we were witches. So there's some speculation that through the witch trials that some of those women were just purely menopausal, and that's why they were thought to be witches, because of the symptoms that they were having. There was a time when they worked out that there was a brain-uterus link, and there is. It's just that then they thought that that link made women susceptible to climacteric insanity. And then, of course, the logical treatment was to just lock them up in an asylum. And interestingly enough, hystera actually means uterus in Greek. By the 40s, they had worked out that menopause symptoms were a result of the lack of estrogen that the ovaries were no longer making. And then the race was on to develop a medication that women could take. And in 1942, the very first FDA-approved hormone replacement therapy was released. It was all the rage. There were lots of campaigns to advertise it. In 1966, there was a book written called Feminine Forever by a U.S. gynecologist, Robert Wilson, who wrote in regards to menopausal women's bodies that they were a galloping catastrophe and that all postmenopausal women are castrates. But with hormone replacement therapy, a woman's breasts and genital organs will not shrivel. She will be much more pleasant to live with, and she will not become dull and unattractive. Apparently, husbands were encouraged to get their wives on hormone replacement therapy to keep them from becoming unattractive and shriveling up, keeping them hot in the bedroom. But then, in the 1970s, they started working out that a lot of these women were getting cancer of the lining of the uterus, so endometrial cancer. It took them a little bit of time, but they finally worked out that the reason that these women were getting endometrial cancer was because when a woman goes through menopause, her ovaries stop making both progesterone and estrogen. So there's an imbalance of two hormones, and you need the progesterone in order to protect the lining of the uterus from the estrogen. If you have the progesterone there, it protects the lining of the uterus so that women then don't get endometrial cancer as a result of the unopposed estrogen. So by the 90s, they had worked that out, and they were then treating women with combined hormone treatment. If they had a uterus, if they didn't have a uterus, they didn't need the progesterone. And so we typically give those women just estrogen if they're going to get hormone treatment. In the 1990s, HRT was the number one prescribed drug in the United States with sales over $1 billion. And then it was speculated that hormone treatment made women healthier. There were a few studies that had alluded to that it decreased the risk of cardiovascular disease in women if they took hormone treatment. So a group of scientists, doctors in America, decided in the 90s that they wanted to do a huge study, a huge trial to prove that essentially there were lots of other kind of reasons for the study, but the main aim was to prove that hormone treatment protected a woman from getting heart disease, that they had less heart disease than women who didn't take hormone treatment. The study was said it was huge. It was over 160,000 postmenopausal women between the ages of 50 and 79. The study was called the Women's Health Initiative. For our purposes today, they took just less than 30,000 of those women and split them into two groups. So there was the estrogen-only group, and then there was the combined hormone group. So the estrogen-only obviously didn't have a uterus, and then the combined hormone did have a uterus. Those two groups were then compared to placebo groups. So there was, one group who got the hormone and another group who didn't. So then at the end of the study, they could compare the two and see how many more people in the placebo group got heart disease compared to the hormone group. But as I said, they looked at a lot of other parameters. So the study was meant to go for about 8 years, and at just over 5 years, they called it quit. It was thought that it was too unsafe to continue with the combined hormone group of the study. They were seeing more heart disease in the hormone group than in placebo. They were also seeing an increased risk of stroke and blood clots and an increased risk of breast cancer. So they stopped the study for the combined hormone group. A couple of years later, they stopped the estrogen-only group as well because they were seeing a slightly increased risk of stroke in that group. Interestingly enough, maybe a decreased risk of breast cancer in that group. So this is the study that changed the landscape for treatment for menopause for women over 20 years ago. And we really have not recovered from that. I want to break that study down today a little bit for you to see for yourself where these numbers come from, where the risk associated with breast cancer in particular comes from, so that you can make an informed decision about whether or not hormone treatment is still on the table for you as a possible option when managing the symptoms around menopause. So I was a medical student in 2002 when this study came out, and it was huge. It made huge news. It was the biggest health news story of the year. It could have been of the decade, I don't know. But I do remember when it came out, it was really interesting because the day that it was published, they had a press conference before anyone really had a chance to look at it, which is really unusual practice in medicine. The press conference was held to tell the whole world the claims that it had made and why it had stopped the study. And immediately, women were terrified of being on hormone replacement. Doctors were terrified to prescribe it. There were stories of doctors asking women to sign disclaimers to not hold them liable if they got breast cancer, heart disease, or whatever. So it was a big debacle, I would say. And I think probably a little bit of a scandal. And I have spent quite some time working through the studies and the numbers, trying to see for myself what exactly went wrong. It's actually really quite confusing, even for me as a doctor, to sift through the articles from that time and try to make sense of what happened and why we're still where we're at now. In the interest of time, I won't go into it today. But if you're interested in learning more about this, Dr. Louise Newsom has a podcast, and she interviewed Professor Rob Langer, who was one of the original investigators involved in that study, who has a very interesting story to tell about the scandalous details. So I will leave a link to that interview for you if you're interested in checking that out. It's a very good interview and a lot of good information. Okay, so let's have a look at the study. I'm going to talk particular about the breast cancer risk because that seems to be the one that most people are really hung up on and the reason why a lot of women just won't even consider hormone treatment. So we're just going to kind of focus on that to start with. So in the study, the combined hormone group increased risk of breast cancer didn't show up until the 3rd to the 4th year. And what they reported was that there was a relative risk of 26% increase of breast cancer in the hormone group. The actual wording in the study is almost reached nominal statistical significance. So it didn't actually reach statistical significance. It almost reached statistical significance. So it really shouldn't have been reported as an increased risk of breast cancer in terms of relative risk increase. Now, if they had put the absolute risk increase in, that's a different story, and we're going to talk about that in a second. One has to wonder, if that claim wasn't made, how much different things would be for women now in terms of managing menopause. Let's talk a little bit more about relative risk. Now, what that means, relative risk compares two groups. The risk of whatever you're studying, so in this case would be breast cancer, the risk compared to the other group. 26%, when you look at that number, that's a big number. And if you're not quite understanding the difference between something like relative risk and absolute risk, it makes sense that that number is going to seem quite big. Okay, but if we break it down a little bit further so we can kind of make more sense of it. If you looked at the placebo group versus the hormone group, in terms of absolute risk, now absolute risk is your likelihood of something actually happening. In absolute risk, we use this a lot in medicine. The absolute risk in this case was considered to be 0.08%. So another way of saying it would be an extra 8 women in 10,000 per year got breast cancer in the hormone group. So it's two ways of looking at it. So relative risk highlights the differences between groups, but absolute risk gives us a better picture of the actual likelihood that something will happen. Generally, you use both of these measurements to help with your decision. One number, if you don't quite understand what that means, looks huge. The risk looks huge. If you look at the other numbers, in this case in particular, it's not an overly huge risk. In terms of this study, what we can say is the formulations that they used, in other words, the actual type of estrogen and progesterone and the method in which it was taken, so in this case, orally, do appear to slightly increase the risk of breast cancer after 5 years of taking it. The newer formulations don't appear to have the same level of small risk. Further putting breast cancer risk into perspective, if you were to lead a sedentary lifestyle, that would be double the risk of what they found in that study. Not that it doubles the risk, but that you would have double the risk of what they found in that study just by leading a sedentary lifestyle. 2 glasses of wine a day would be about the same level of risk. Carrying significant excess weight, so obesity, again, same level of risk. Now, a few other take-home messages about the study, especially when we're looking at the other things that they were concerned about, the increased risk of cardiovascular disease, blood clots, and stroke. Now, the median age of the women in the study was 63, which means that half of them were older than 63 and half of them were younger than 63. But what we know is that the majority of them were over 10 years from menopause. What we know about age in itself is that it's a risk factor for lots of things, right? And as we age, especially after menopause, we know that women become at increased risk of cardiovascular disease. One of the great things that came out of the study is that we now know that if you give a woman hormone replacement after that 10-year window, then it's likely she may have already started to build some of these plaques in the vessels around her heart. And if she's got plaques in the vessels around her heart, she very likely has plaques in the vessels in her brain, which could then predispose to stroke. And so we now know that giving the hormone replacement now at that time can increase her risk. If we looked at those women who got the hormone treatment within that 10-year window, it actually decreased the risk of cardiovascular disease. We also know, as I said, that age increases most things. So your blood clotting risk is going to increase as you age as well. And so it would make sense that you would get more blood clotting in this older age group as well. The estrogen that they used in the study was an estrogen that we don't tend to use as much these days. It's still used, but the estrogen that was used in the study is extracted from the urine of pregnant horses, and it contains something like 10 different forms of estrogen. We now tend to use a lot more estradiol, which is closest to what our body makes, and we tend to use it in a topical form, which is thought to be safer. So through the skin, either with a patch or a gel here in Australia. Now, an important note here about body identical. Some may refer to what I'm talking about with the estradiol as body identical. I'm talking about hormones that are prescribed by a doctor, that are regulated by the government, so that when you get your medication from the chemist, it comes with a leaflet in the box that tells you about all of the risks associated with it, etc., how to take it, not the type that's compounded. Compounded hormones are not recommended because they're not regulated, and we don't know how much hormone you're actually getting in the formulation that's compounded. So compounded is a specially made up formula by the chemist. The problem with not knowing exactly how much of the hormones you're getting when you have the compounding formula, remember back to when we talked about unopposed estrogen in the uterus. So if the progesterone that you're getting isn't in a high enough dose to oppose the estrogen, then you would be at increased risk of endometrial cancer. And some formulations, like with a progesterone that's topical in a lotion or a cream, isn't going to be absorbed enough, again, to give you that protection. So that's the reason that compounded hormones aren't recommended and can be unsafe. Okay, so the estrogen that we use more now is given either with a patch or with a gel. So it's a topical estrogen. What we know about estrogen in a tablet form is that when it's processed by the liver, something happens in that process that increases the risk of blood clots. We would be very careful giving an oral form of estrogen to someone who is at higher risk of getting a blood clot. So if they're a smoker or they're obese or they're advanced age, those are certainly times when we would be looking at alternatives to an oral estrogen, something like some type of topical estrogen. The progesterone that they used in the study is a progestogen, so it's a synthetic molecule that's made in a lab to mimic progesterone, the progesterone that our bodies make in the ovaries. Our newer progesterones are considered to be lower risk, and now more often we tend to use something called micronized progesterone. It's also made in a lab, but has the same chemical structure as the progesterone that's made in the body. So some of the other risks to consider with hormone replacement is gallbladder disease. So getting gallstones, that's one of the higher risks of taking hormone replacement. In that study, there were 45 to 58 additional cases per 10,000 women. But if you use a transdermal approach, so again, a gel or patch with the estrogen component, then there's no increased risk of gallbladder disease. So for the majority of women, the benefits of hormone treatment outweigh the risk. There's definitely a decreased risk of osteoporosis with hormone treatment, a decreased risk of colon cancer. It can decrease the risk of diabetes, it can decrease the risk of heart disease, and it manages the symptoms of menopause. Now, who shouldn't take hormone treatment? If you've had breast, endometrial, or other hormone-dependent cancers, either now or in the past, then you shouldn't be taking hormone treatment. If you've got any kind of undiagnosed vaginal bleeding, that needs to be sorted out. You shouldn't be on hormone treatment until that's sorted out and you know that it's safe to take. Now, relative contraindications, things that we just have to think a little bit more about and may look at something like a transdermal approach, would be if you already have heart disease. That needs to be further worked up, and the risks need to be further stratified, is what we call it. We would do more work to see exactly what we're dealing with, and then we'd sit down and talk about the risks. So those are things that really need to be hashed out with your doctor. But in some of those cases, a transdermal approach might be appropriate. If you have a history of blood clots, we know that the transdermal approach is safe. If you have active liver disease, again, a transdermal approach is safe. So that's just about it for the talk about HRT today. My intentions were to hopefully dispel some of those myths around this crazy increased risk of breast cancer that most people seem to associate with hormone treatment. I hope that you got a lot out of this. I hope that you can now see that what we've been afraid of for all of these years is what boils down to a very small risk. You may feel that that risk is still too great for you, and that is your prerogative. But it's important to me that my patients understand exactly what the risks are so that they can make informed decisions about their treatment. So take this information to your doctor and have a chat with them if it's something that you want to explore further. As I've mentioned before, hormone replacement is not the only tool in the toolbox. In fact, there are some things that we really should be doing that are not medical, that are not tablet forms, that are not taking medicines. And I will explore those in future episodes of Opt to Thrive. But I think that we've covered enough today for you to have a think about. So with that, I hope you have a great day, a great couple of weeks, and until then, I hope you opt to thrive. The Opt to Thrive podcast is designed for information purposes only and is not engaged in the giving of medical advice. The information provided on the podcast should not be used for diagnosing or treating a health problem or disease. In no way should the information provided by Opt to Thrive be considered medical advice, and at all times the advice of a medical professional should supersede recommendations from Opt to Thrive. If you have or suspect you may have a health problem, you should consult your healthcare provider. The views expressed in this podcast are purely that of Dr. Sims and do not in any way reflect those of the institutions she contracts her medical services to.
Thank you for listening to Opt to Thrive. If you've enjoyed listening, please rate and share the podcast. You can visit our website at www.opttothrive.com and leave a comment for any subjects you would like to hear more about.